Okay, so let's continue with the more practical part of my talk. So in this second part I will present 3 cases where the gait analysis was used to monitor the certain intervention or intervention of particular treatment. In the first 2 cases, the third case is more or less a research case. And in all these 3 cases, the gait analysis was performed, or a certain type of gait analysis, certain aspect of gait was analyzed. So let's first take this first case in which we were studying the effect of the long-term perturbation training in patient after stroke. So this was a 53 years old male. He was 8 months after stroke, right-sided hemiparesis. He was considered to be high-functioning, community-dwelling person, and he was able to live independently. He completed 2 months of rehabilitation program prior to joining us in this study. So I work at the Rehabilitation Institute in the research unit, and once in a while we try and develop a certain device or a system that allows us to study certain aspect of gait. And in this particular case I would like to explain how the perturbation training device was used to assess the effect on the gait it had if the person was subjected to a long-term training. The device was developed at our unit, and let's first look at the video of this subject walking in our gait lab, and let's try to identify what are the most dominant gait deviations that one can observe in this video. So the first thing that we notice is that the gait is very slow. The range of movement on the right side is quite reduced. The support is prolonged on the non-paretic side, on the left side. And what we also see is that the right side of the pelvis is elevated, which probably is to ensure sufficient foot clearance due to in the swing phase. So let's first look at the spatiotemporal parameters of gait, and let's try to identify, this is the task number 1, let's try to identify the most dominant deviations between the left and the right side from the spatiotemporal parameters of gait, and then in the second task let's try to put the information in this table on the plantar flexion graphs on the right side. So what we notice is that there is quite substantial asymmetry between the left and the right side. We again can see that the support that on the right side the support phase is quite shorter. So if we notice the opposite foot off event on the right, is where the first double support ends. We see that for the left and the right side this is quite consistent, so it's approximately the same. What we notice then is that when the second double support period occurs, we see quite considerable difference between the left and the right side. So there is the stance phase is being extended on the left side and is being shortened on the right side. So this is where the symmetry is being mostly notable, and this is what confirms that this subject was trying to prolong the support on the non-paretic, the left side of his body. So again, this is the combination of gait kinematics and kinetics. So the gait kinematics is here on the top left panel, the gait kinetics is on the bottom panel, and the ground reaction forces and the center of pressure. Pressure is here on the right. What we notice is that there is a And let's try to now identify what are the most dominant, let's say, discrepancies between the left and right side and deviations from the normative data. The normative data are presented with the gray area. So if we try to mark this data, what we notice is that there is a considerable shift in the pelvis in the anterior direction. What we notice is also that on both sides there is a increased flexion during the stance phase, and on the right side we see that there is almost no range of movement during the stance phase on the right in the knee joint. And what we also see, there is a considerable shift towards the dorsal flexion, and also very small range of movement in the ankle joint at the end of the terminal phase. What we also notice is that on the right side, the center of pressure is, let's say, somewhere in the middle of the foot. And what we also see that there is a very poor modulation of the horizontal component of the ground reaction force. This, if you remember from the previous talk, we normally have quite explicit ground reaction force here during the push-off phase. And this is now lacking here, meaning that there is little forward propulsion present here. What we also notice is from the kinetics part of the data is that there is an extension or an increased hip extensor moment, which is actually present here to compensate for to keep the pelvis and the torso in the increased forward tilt. What we also notice is that the knee flexion moment is present instead of the normal knee extensor moment on the right side, whereas on the left side it is quite normal trajectory of the knee flexor moment. What we also notice is that there is that there is a lack of push-off, so the terminal stance is characterized with the push-off. The push-off is actually achieved by rapidly extending the ankle joint, also the leg, the knee joint, and there should be higher anchor dorsiflexor moment in the plantar flexor moment present during the push-off time, and that results in the quite diminished ankle power generation during the push-off. What we also notice from the vertical component of the ground reaction force is that there is a quite evident difference where the stance phase ends. So we see that on the right side it ends sooner, quite sooner compared to the left side. So now let's look at these two pictures. There is a joint moments, the hip, knee, and ankle joint moments on the panel on the left, and the center of pressure displacement in the anterior posterior direction on the bottom. And here we have skeletal diagrams, and let's now try to draw the direction in which the ground reaction force acts on the right side, and try to draw the direction here in the skeletal diagrams. So the first position represents approximately 10% of the gait cycle here. And if you remember from the previous talk, we said that the muscles have to generate a joint moment that would counteract the effect of the ground reaction force. So for example, if we have a plantar flexor moment here in the ankle joint, this means that the plantar flexors on the posterior side of the ankle joint are being active. If plantar flexors are being active, then the ground reaction force has to pass the ankle joint on the anterior side. We also notice that from the center of pressure graph here is that the center of pressure is somewhere here in the middle of the foot immediately after the initial contact. In the knee joint, we notice that there is a very small moment here present, meaning that the ground reaction force will pass the knee joint very close to the center of rotation, and in the hip joint, we notice that there is a slide here in this area. There is a very small extensor moment present, so the ground reaction force has to pass the knee joint, the hip joint, approximately somewhere around center, perhaps a bit anteriorly. In the mid stance phase, so approximately at 30%, what we notice is that the center of pressure is slightly moving ahead, so it has been shifted slightly towards the toes. What we notice is that there is the plantar flexor moment being generated, so the ground reaction force has to pass the ankle joint in front of the ankle joint. There is a slight flexor moment present here in the knee joint, so the ground reaction force has to pass the knee joint on the anterior side, slightly on the anterior side, almost crosses the axis of rotation because of the small amplitude of the torque. And in the hip joint, again, there is a very small moment present there, so the ground reaction force should be close to the hip joint in the mid stance. In the terminal stance, we see that this is the end of the support. The center of pressure is being shifted towards the toes. What we notice is that there is this is the peak ankle plantar flexor moment here. So if there is a peak ankle plantar flexor moment here, the ground reaction force has to be farthest away in the anterior direction. And again, in the knee joint, there is a very small flexor moment here, meaning that it has to be, the ground reaction force has to pass the knee joint on the anterior side, and a very small moment in the hip joint, meaning that it has to pass approximately very close to the hip axis of rotation. So what can you say about the gait for this particular patient? What we notice is considerable gait asymmetry. He is prolonging the support on the left side, the non-paretic side. There is almost no push-off on the right side. There is a modest or lack of forward propulsion, and the right knee has quite limited range of movement during the stance phase. So let's say it's almost locked, and that is why the ground reaction force is in front of the knee joint, and due to this reason we notice that there is a dominant flexor moment present in the knee joint throughout the stance phase. So as I said, this subject was subjected to a perturbation training for a longer period of time. This training lasted for approximately 10 weeks, approximately 2 months or almost 3 months. And he was subjected to 30 training sessions, 3 training sessions per week. The training session consisted of 10 to 15 minutes of unperturbed walking, and then 30 to 45 minutes of perturbed walking. Perturbations were delivered approximately every 6 seconds in the inward outer direction, so left and right direction, forward and backward direction, and the direction of the perturbation impulse was randomly selected. The perturbation impulses occurred either at the time of the left or the right foot strike, and the amplitude varied from somewhere between 50 and 100 newtons, 50 at the beginning of the training and 100 towards the end of the training. And this is how the training looked like. This was the device that was built in our research lab. So it's a haptic device, motorized device that is able to deliver force field to the pelvis of the patient or individual force pulses, impulses to the pelvis, and the walking, so the measurement is done on the instrumented treadmill so that we can measure the ground reaction forces, also the center of pressure. We measure also the position of the pelvis. And after the training, this is the gait of this patient after the training. So what are the most important or the most evident improvements, if there are any, that we can identify in this gait? Well, what we can notice is that the gait is faster. I would also say that the support on the paretic side is longer. Let's see it again. The support on the paretic side is longer, and I would say also that the asymmetry decreased quite a lot. So let's look at the spatiotemporal parameters of gait before and after the training, and let's try to identify how the improvements of gait reflect in the spatiotemporal parameters of gait. So what we notice is that the gait was faster. Also what we notice is that the differences between the left and the right after the training decreased in those parameters that are marked in red. So the foot off parameter decreased, which indicates the duration of the stance phase, and also the other data decreased as well. So, yes.
Yeah, we have the question from the audience.
Yes.
So in the hands-on session, the PDF, you mentioned the limb index.
Limb index.
Yes. Can you say a couple of words about it? How it's calculated?
Limb index is an indication of how symmetric the left and the right support is. So I don't know exactly how it is calculated, but I think it's the ratio between the ratio between the duration of the stance phase on the left and on the right side. Mm-hmm. I think, but I'm not really sure.
Okay.
Yeah.
Thank you.
Okay, so let's now continue with the gait kinematics and kinetics, and let's observe what changes occurred in gait kinematics after this long period of perturbation training. So, and let's try to mark them in these graphs. So, what we notice is that particularly that the modulation of the ground reaction force has now improved. The range of the ankle movement at the end of the terminal stance has somewhat improved. The plantar flexor moment during the loading response has somewhat decreased, which indicates that the center of pressure has shifted after the initial contact slightly towards more to the posterior direction. We have improvements in the push-off power in the ankle joint. One of the most important improvements is probably that in the knee joint we now have the knee extensor moment instead of the knee flexor moment, and also the range of the movement in the swing phase increased on the right side. What we also notice is that the range of movement in the hip joint increased, and because the pelvis is no longer tilted in the forward direction, so to such a large extent that this was before the training, we noticed that the so large extensor moment in the hip joint that was previously needed to actually keep the pelvis and the torso in the upward direction is no longer needed.
Andrej?
Yeah.
We have another question regarding the perturbation training. So how it was So did the training continue at home by other means? It's being asked from the chat, or it's done only in your hospital, and then people or these patients keep coming and going home?
Yeah, so we only have one of these devices. This device is stationary and it's quite bulky, so it cannot be shifted even to another room. So all the training was done here. The patient was coming in 3 times a week and spent approximately 1 hour with us, training during that period of time. What I can say that he was quite happy with the training, and he was also happy about the results. He said that he actually feels that the things have changed after the training. So no, it was going on in our gait lab, in our research lab.
Okay, and to top up this question, Martin is asking, does the training somehow target the issues identified in gait kinematics and kinetics? And if it could be briefly explained how.
So this device allows several different, let's say, modes of training. So this device can apply perturbation impulses or the force field on the pelvis. So what we have seen from the gait analysis is that the patient was prolonging the support on the non-paretic side and was shortening the support on the paretic side. So what we wanted to see is, let's say that at the time of the right foot strike, what happens if we apply the soft perturbation that is not an impulse, but it lasts over a certain period of time, let's say half of the support phase, forcing the subject to actually increase, to shift the weight more to the paretic side. If this eventually would come to result in a situation when the person would do that on its own. And what we have seen that we actually did achieve to some extent that there is not perfect, it is not perfect yet, but there was some progress in this direction. So we did target those specific asymmetry questions that were present before the training.
Okay, and again, like another question we have here is how is it related to like overground walking versus treadmill walking? So as far as I know, Mohammed said the force production on treadmill is different with walking on like overground walking.
Yeah.
So how do you?
So there are studies that did compare the overground walking and the treadmill walking, and there are some differences, but we use treadmill here only for the training, not for the analysis. So the analysis was done in the gait lab, which was always overground, so there was no outside, let's say, interaction. Whereas on the treadmill, instrumental treadmill, what you get is because of the moving surface, you're actually being pulled in the backward direction. So this is one of the effects that has been described in the literature to have some effect on the human gait.
Yeah. And one last question for now is just like if this device is currently commercially available, or you have it at your institute and that's limited. So this device is not commercially available because if you want to commercialize such a device, you have to certify it first. And certification process is quite long and tedious, and now the directive has changed, and you need to have a lot of data to show that there is some let's say you have to prove that certain things do improve due to the training, for example. Also, the cost of such a device would be enormous because we have like 6 linear actuators that control such a device, and the production cost would probably be quite high. But what we are doing now, so this device is now retired, but we are already developing a new device, very simple device that would use off-the-shelf components, very standard DC motors that are, let's say, apart from the perturbation period, are detached from the human. So the only interaction with the system is when there is a transmission of the energy between the machine and the person, but otherwise they are mechanically separated, which ensures the safety of the training subject.
Thank you so much.
Yeah, welcome. Thank you for the questions. So we stopped here, I think. Yeah, so we said what important improvements did we record. So one of the most important improvements was getting the flexor moment to shift in the direction towards the extensor moment. So now we have another task. Let's try, based on the ground reaction force, to draw in which directions or which moments are present in each individual joint in these three, let's say, phases of gait. Again, we have the weight transfer on the far left graphics, mid stance in the middle, and the terminal stance on the right. So if you remember from the previous part of my talk, if the ground reaction force is on the anterior side of the joint, then the muscles on the other side of the joint has to counteract the effect of the ground reaction force, and this is something that we would get. So the first graph shows that ground reaction force is in front of the ankle joint, so the plantar flexors have to be active. The ground reaction force is here behind the knee, so the knee extensors have to be active, and also the hip flexors. In the mid stance, again, the center of pressure shifts towards the forefoot. We now have quite explicit plantar flexor moment. It passes the knee joint on the posterior side, but it's quite close, so we have a small extensor moment here in the knee joint and flexor moment in the hip joint. And situation is quite similar also in the terminal stance. So what did we achieve in this particular case? We did enhance or improve balance mechanisms. The modulation of the ground reaction force was better. We improved the gait symmetry. The support was prolonged on the paretic side as compared to before the perturbation training. The push-off did improve, and the ground reaction force shifted in the knee joint from the anterior to the posterior position, so that now the patient was able to generate knee extensor moment, so the extensor muscles were being activated, which is a normal pattern in every healthy walk. So now the second example is the quite common intervention in the children who are toe walking. So serial casting is a procedure when we try to improve or increase the range of movement in toe walking subjects. So this was a 6-year-old boy, 7 years. He was old 7 years at the final gait analysis. He had normal early development, but started walking at the age of 18th month, and even quite early after he started walking, he displayed a toe walking gait pattern. So meaning that initial contact was occurring with loading of the forefoot instead of the heel, which is a normal gait pattern. Clinical tests have been performed to test the range of movement in the hip joint, the knee joint, and the ankle joint. And what we did see is that in the hip joint, the range of movement was quite okay. But the range of movement in the ankle joint was reduced, and even more reduced in the ankle joint. So this is the gait of this particular youngster. What we can identify here is immediately that he actually displays a quite characteristic toe walking pattern. So the loading occurs on the forefoot. If it happens, the heel then later touches the ground, but it doesn't seem to be so. What we also notice is the deflection during the swing phase is
in the knee joint is somewhat decreased. So let's look at the spatiotemporal parameters of gait. And again, let's try to find what are the differences between left and the right leg, and try to put this data onto this graph on the right. So let's try to put the foot off, the opposite foot off, the opposite foot strike into this graph on the right. Let's try to mark the single support phase, the double support phases, and the swing phase. So as far as these numbers in this table goes, we see that there are not actually the differences between the left and the right side are not very big. So it's almost the same. And if we put these numbers into the graph on the right, what we notice is that all these events are quite aligned between the left and the right side. So the first double support is somewhat shorter on the right side, but not much. We notice that the whole stance phase on the right side and on the left side is approximately the same. Again, the second double support starts approximately at 50% and lasts for the left and the right side the same amount of time. And also the swing phase lasts for about 40% as normal. But what deviations can we find in the gait kinematics and kinetics? So again, the top graphs show gait kinematics, gait kinetics here on the bottom, and what we also see here is the ground direction force in the anterior posterior direction, the vertical ground direction force, and the displacement of the center of pressure. And if you start here, is what we notice is that there is a quite significant shift of the center of pressure towards the toes, which is what we also have observed in the video that we saw earlier. So this confirms that that the initial contact occurs with the forefoot, and because of the forefoot contact at the start of the gait cycle, we get this quite marked shift towards the dorsiflexion. Because the ground reaction force is quite so far in the anterior position with respect to the ankle joint, we have this quite large peak of the ankle plantar flexor moment that has, and this moment has to counteract the effect due to the ground reaction force. And because we have a plantar flexor movement, we have a plantar flexor moment and the movement in the dorsal flexor, we get this exchange in the energy absorption here, the first peak in the negative direction, and the power generation, the second peak when the direction of movement in the ankle joint changes the direction. What we also notice is that, again, similar as in previous case, in the knee joint, the knee flexor muscles are producing the knee flexor moment, and that the knee joint is, we have a quite reduced range of movement in the knee joint throughout the stance phase, and also we have a reduced range of movement in the swing phase. And what we also notice is that there is a quite significant forward tilt of the pelvis. So let's now look at the EMGs and what the EMGs tells us, and let's see if this is in line with the story on the previous slides. So let's try to identify the deviations here in the EMGs. So we have in the quadriceps, there is a shortage of activation during the loading response, during the initial contact and then during the loading response, which is quite consistent because the ground reaction force, as we will see, is actually passing the knee joint on the anterior side, and as we saw on the previous graph, the knee flexors have to counteract the effect of the ground reaction force. What we also notice is that there is a quite significant increase in the activation of the plantar flexor muscle groups. So when we get immediately at the start of the gait cycle and when the weight is being shifted towards the leg in stance, we notice that both of these groups, both of these muscles are quite active. What we also notice is that there is a lack of activity in the tibialis anterior muscles. Oh, I did. So the lack of activity during the weight transfer because of the toe contact. So what we notice is that before the intervention, we noticed the quite extensive toe walking pattern, extensive plantar flexion in the ankle joint, and nevertheless the gait is quite symmetrical. So what is a serial casting? Serial casting is a non-invasive conservative method used to improve range of motion in joints, and it is used to stretch tight muscles that would otherwise not stretch enough solely with exercise, and plaster is being used to hold the position of the ankle joint and the foot in the right position for a longer period of time. So typical duration of this intervention can be 4, 5, 6, 7 weeks, and often it is during that period the plaster is being replaced and the position of the foot and the ankle joint is being corrected and again limited with the plaster. So what we want to achieve is to gradually improve the range of movement in the ankle joint. So we want to decrease the ankle plantar flexion throughout the gait cycle so that the patient would be able to initiate the foot contact with his heel instead of the toes during the time of the initial contact. So let's make a simple prediction. Assuming that the serial casting would have the effect that we would desire, and this is the skeletal diagram of this child during the loading response, what changes do we expect would occur after the intervention? So if we know that the serial casting would reduce the plantar flexion and the toe walking will not be present anymore. So one of the first changes that we expect is that the ground reaction force or the center of pressure would shift towards the ankle, ideally towards the heel at the time of the foot strike. We would then expect that the plantar flexion would no longer be such excessive, so the ankle would shift towards the dorsal flexion. If this is true, then what we would also expect, the first peak that was previously present in the ankle plantar flexor moment would no longer be present. Also, what we would expect, that the direction in which the ground reaction force is crossing the knee joint would change from anterior position to the posterior position, meaning that there will be activation of the knee extensors. So these are ideally what we would want to achieve. So let's see what happened. Oh, let's first also try to identify what changes we would want to, if the casting is successful, what changes we expect to occur in the muscle activation patterns. So let's start on the right. So the plantar flexor muscle group, we expect if the serial casting is successful, that such an excessive activation of plantar flexor muscles would no longer be necessary immediately when entering the stance. What we also expect is that the quadriceps would increase their activity during the loading response if the ground reaction force shifts in the posterior direction with respect to the knee joint. We also would expect that the tibialis anterior activation during the initial contact would increase. And perhaps the knee flexor, the hamstring muscles would decrease this activity here because the knee flexor moment would no longer be necessary. So these are our predictions. So the tibialis activity would increase, the quadriceps activity would increase here, the activity of plantar flexors would decrease here immediately after the contact. So this is the child after this period when he was equipped with the plasters. And what we noticed that, again, that as we hoped for, the toe walking was reduced, and it actually makes the loading with the heel. So the first contact is made with loading the heel instead of the forefoot. And I would say also that the range of movement in the other joints has increased to some extent. So let's see how these changes reflect in gait kinematics and kinetics. Again, the top graphs show the gait kinematics, the bottom graphs gait kinetics, and the vertical and the horizontal ground reaction forces here on the right, as well as the center of pressure. So let's look at the center of pressure first. What we notice is that the center of pressure indeed did shift towards the heel. So we no longer have the center of pressure being present here at the forefoot or near the toes. It has shifted in the direction towards the heel. What happens is that because of this, there is no this exchanging period of power absorption and generation needed in the ankle joint. There is no longer needed this excessive ankle plantar flexor moment here. The plantar flexor moment did increase somewhat here during the push-off. The range of movement in the ankle joint has shifted toward the normal values. Also, the range of movement has improved in the ankle joint, in the knee joint. And in the knee joint, what we also now notice that instead of flexor moment that was present before the intervention, we now get an extensor moment being present in the knee joint. What we also notice is that the pelvis is no longer inclined so much in the anterior direction as it was before the intervention. So let's see if our prediction was correct in the EMGs. So what happened? Let's start with the plantar flexors. So we indeed see that the activation of the plantar flexors did reduce, but it still remains. It still remains here. It did reduce to some extent, but there are still some activation present here. And here at the end, we again show that the activation of the gastrocnemius muscles has decreased. What we also notice is that the quadriceps activity during the loading response and the initial contact is increased. This is in line with the knee extensor moment that is now present after the intervention. Again, we notice that the tibialis anterior activity is becoming more normal, but there is still excessive activity here during the swing phase, and this activity probably is associated with the fact that there is still some activity present in the plantar flexor moment, so they need to counteract that activity in the swing phase. What we also notice that during the loading response, a slight change in the hamstring muscle activation. So what did we achieve by applying serial casting in this particular child? So first we achieved that the toe walking was successfully managed, the push-off did improve, and now after the intervention, the knee extensor moment is dominant as opposed to the flexor moment that was dominant before the intervention. But what we see is that there is some increased plantar flexor activity present during the loading response, still present even after the intervention, but this is not uncommon because oftentimes such intervention is repeated several times during the childhood. This is something that occurs that can occur, and we try to use these conservative methods as long as possible throughout the childhood. So this particular case here is more a research case where we were trying to assess dynamic balancing responses in persons with unilateral transtibial amputations. So a lot of our work is focused on the balance and gait, also not only for the healthy and the CP children and the stroke, but it's also for the researchers for the purposes of the research. So in this particular case, we focused on the transtibial amputees, and we wanted to see what the responses to be to outside perturbations if they are perturbed while they are in the stance phase on their amputated or non-amputated side. So whether there are differences in the responses, which we of course expect to be. So we invited 14 subjects that were that participated in this study. The inclusion criteria was that that they have a unilateral transtibial amputation, that have a long period of time have been using their passive prosthesis. They needed to be able to walk without walking aids, and they mustn't had other musculoskeletal conditions. And we also included 9 control subjects to whom we then compared the results to. So the experimental protocol was as followed. First, the training session or the experimental session began with 3 minutes of unperturbed walking, then 7 minutes of perturbations. We used our balance assessment robot, the same robot that was used in the first case for the long-term perturbation training. And this device was then used to deliver perturbations to the pelvis. And this device was used then in combination with the instrumented treadmill, so that we would measure the data associated with the balance responses. So they were subjected to perturbations in the inward, outward direction, forward direction, and backward directions. And we wanted to, so these directions were randomized, so perturbations were delivered in random direction. And we wanted to have at least 7 repetitions for each perturbation direction. So that we could have an average them. The amplitude of the perturbation was set to 10% of body weight, and the duration of the force impulse was set to be 150 milliseconds. The data that we measured was not entire the entire kinematics and kinetics of all lower limb, but it was only the center of mass position, displacement of the center of pressure, and the ground reaction force. And we obtained 3 data sets. First, the responses, so the center of pressure, the center of mass, and the ground reaction forces for the normal subject. Then for the amputees, when they were perturbed on their non-amputated side, and the same data when they were perturbed on their amputated side. And these are the results that we obtained. And again, the top line shows the center of mass in the anterior-posterior direction for the control group, for the non-amputated group, and for the amputated group. So the non-amputated group are the data when the amputee entered the perturbation on the non-amputated side, and the amputated data were present the data when the amputee subject entered the stance phase with their amputated side, and then they were perturbed.
So the top graphs show the displacement of the center of mass in the anterior posterior direction and in the medial lateral direction. The middle graphs, the middle line shows the displacement of the center of pressure in the medial lateral direction, the anterior posterior direction, and the bottom graphs show the ground reaction force in the medial lateral direction and the anterior posterior direction. So if we focus on the center of pressure in the medial lateral direction, below we have the footprints and the direction of the perturbation with respect to those footprints. So this is the inward perturbation. So meaning that perturbation occurred in the lateral direction with respect to the foot that entered the stance phase. So from looking at these graphs here, the center of pressure in the medial lateral direction, let's try to see where the next landing points for this leg would be for the perturbed gait. So this is the unperturbed footprints, where the position of the footprints would be if the gait were perturbed. So if we look at these graphs, we see that there is a slight displacement with respect to the unperturbed walking in the control group. Somewhat bigger displacement of the center of pressure in the non-amputated group, meaning that the footprint would shift in the direction of the perturbation, so towards in the lateral direction. When entering the perturbations with their amputated side, we again see quite similar pattern also for this group of data. So we have quite similar response to the perturbation in this group, in this set of data. So for the inward perturbation, in this perturbation. But what happens if we change the direction of perturbation? So now the perturbation direction is in the lateral direction. So in the directions, in the right direction if the foot strike is on the right side. Again, we have the footprints of the unperturbed walking. The direction of perturbation is in this side. And let's try to identify the new footprints. Where would these footprints be displaced if they are perturbed in this direction? So again, following this graph, we notice that there is a slight displacement of the footprint in the control group. So they were able to manage to withstand the perturbation and continue with quite normal foot placement pattern. When the amputees entered the stance phase with their non-amputated side, again there is not a lot of difference in the foot placement in the next step. But if they are perturbed while their amputated side is in the stance phase, then what we see a considerable displacement of the next foot strike in the direction of the perturbation. What we also see, this small peak here in the ground reaction force, this is an indication how that they develop an instant strategy. So they use the ankle to actually counteract the perturbation. And this is the resource that is missing here on their amputated side. So we don't see this, let's say, response in the ground reaction force. And the ground reaction force in the medial lateral direction actually decreases, which allows then to shift the foot placement in the direction of perturbation. So to conclude with this particular case, what we notice is that when the amputees are perturbed on their non-amputated side, they develop similar instance response as persons without amputation. But when subjects, amputees, are being perturbed on their amputated side, they don't develop this instant strategy because it relies heavily on the ankle involvement, which is the resource that is missing in the amputees, subjects on their amputated side. Rather, they use an alternative strategy, which is they
reposition the foot placement and respond to the balance after the next foot contact. So thank you for your attention, and with this I would like to conclude, and if there are any questions I would be happy to answer them.
Thank you very much, Andrej. We do have some questions. First of all, like a general one, how far from the implementation of mobile brain body imaging into clinical practice are we? So you clearly showed like a very detailed analysis of kinetics, kinematics, EMG. So perhaps a step towards like the implementation of MoBI would be like perhaps like switching from Vicon OptoTrack systems to XSense Moven. How far are we from that, let's say, position?
So I've been working with XSense before, so I had the opportunity to see how their system works. I think that we had a project with the Faculty of Sport in Ljubljana. I also know that there is a strong initiative to, let's say, to avoid all this marker placement, which is now necessary within those marker-based systems like Vicon or OptiTrack or OptoTrack and so on. And they are going in the direction where they would like to calculate kinematics while walking on a treadmill, instrumented treadmill, solely based on the video. So this is like a image processing, some kind of probably artificial intelligence. I don't know, I'm not familiar with this. But from the presentation videos that I have seen, it seems quite interesting, and I don't think that this is so far away from being actually used.
Yeah, we actually have seen like a presentation using deep learning, and these algorithms applied solely observing that
based on the image.
On camera. Okay, but I actually visited myself your laboratory at Socha Rehabilitation Center, and what surprises me is somehow that you have a very complex measurement already established. So if the person comes there, you spend like an hour and a half to prepare or even more, and then you do the measurement, and there are kind of like complex analysis running afterwards, and then there is an interpretation of like many experts. So to add this question, so if we want to add like the brain dynamics into that would like increase enormously the complexity of the whole system as it is right now. So is the answer that there is no room for that implementation yet, or do you see some like simplification that could occur in the next years?
Yeah, good question. So these protocols of measuring gait in the gait lab, so for the clinical purposes, is standardized. And what we have seen that the demand is growing, is not increasing. So despite the complexity, there is no shortage of the interest. Of course, they are developing new technologies that would try to skip all this, let's say, tedious work of placing the markers and interpreting data. So I think a few years ago I actually was in one lecture when they said that, you know, there is, for different pathology, there is quite specific gait pattern. And there are not, well, there are many pathologies, but the implementation or how they reflect these pathologies in gait data, you get different gait patterns. And there were some suggestions that there is some correlation between the pathologies and the gait data. So I know that there was some research in this direction when they could, from the gait data, automatically extract, or from the pathology automatically, let's say, try to foresee what the relationship between the kinematics and the pathology is. So, but I'm not sure how far it went so far. So.
We must say, like, also from the comments receiving here, that thank you for doing this research. It's really important, and helping like different pathologies and patients that you showed. It's extremely important. With that, I think I'm just checking all the other comments, and very nice presentation. Thank you for the good introduction into biomechanics and so forth. With that, I think we can slowly close this session. I'm pretty sure that Andrej will be available also for you if you have like any other questions. You can place them or post them into YouTube channel, and we'll try to reply on that later on. And I'm sure that you kind of like with this first session or first two sessions got the idea of the complexity we are looking here at. And usually, like looking at the MoBI related studies, we see just like a tiny bit of the biomechanics in, and mentioning the gait speed or step length, symmetries and so forth, but not even mentioning it. By representing those examples that you could see today, that Andrej really nicely showed, you can then see how the more complex biomechanical MoBI research should look like. So with that, I would like to close this session. Thank Andrej once again. And after a short break, we continue on with the pre-recorded session of Andy. Thank you so much.
Thank you.